we are going to the abnormal part. With the above review, we can go quicker. Lack of normality is abnormal. So if the CA is 36 weeks, but the background still shows discontinuous pattern, no stage differentiation, we call it immaturity or dysmaturity, indicating encephalopathy. Active appearance of abnormal pictures is grossly divided into epileptiform and non-epileptiform. We start from epileptiform discharges, which usually indicate seizure disorder. Remember, we don't just read EEG, we study and interpret in the context of clinical information. For newborns, not only EEG, but also clinical features are totally apart from those of older children. The neonatal period is the most vulnerable of all periods of life for developing seizures. They have distinctive characteristics of neural anatomy, neurophysiology, and pathogenesis. Seizures have been shown to have a focal onset, and in contrast to seizures in older children, most seizures are symptomatic of an acute illness. An extensive search for an etiology is mandatory. In 2017, ILAE proposed a latest classification of seizure types and epilepsies, as you may know. Classification of epilepsies. Infantile seizures have put in like epileptic spasm, behavioral arrest, but not neonatal seizures, though they do have a draft for neonatal seizure classification at the website. For years, we used Dr. Volpe's classification of neonatal seizures, which include subtle, chronic, tonic, and myoclonic. They may or may not have simultaneous EEG seizure activity, so we know they are clinical only, electroclinical, and electrographic only seizures for neonates. In this draft, a preliminary framework is proposed, adapted from 2017. Video EEG is needed. Only with EEG correlates are seizures. Then divided into with and without clinical signs, electrographic only. If with clinical signs, further divided into motor, non-motor, and unclassified. Another adapted framework in the etiology, hypoxic is highlighted and separated from structural because it is the most common etiology in this age. Still, it is preliminary. We are expecting an official document to come out in the near future. So, the correlation of electric seizure activity with the occurrence of clinical seizure is critical. Interictal EEG, interictal epileptiform discharges rarely aid in diagnosis. Yet, there are interictal EEG features. Background EEG activity is very informative, including diffuse and focal abnormalities. There are focal sharp waves and spikes, but rare or no generalized epileptiform discharges. Diffuse abnormalities include prolongation of IBIs for the age, depression and lack of differentiation, episodes of generalized and regional voltage attenuation, a very unique pattern cord suppression burst, and the gravest, electrocerebral silence. This is a newborn of CA 40 weeks with encephalopathy and seizures. We can see the discontinuous background activity. This is a 1-month-old full-term boy with dysmorphism, poor activity, and NG feeding. We can see the asynchronous background. A very pathological picture of this one. From a 1.5-month-old girl, the suppression burst. This is a 2-day-old boy with unremarkable perinatal course, having seizures at day 2, soon transferred to our ICU. When we first put on the EEG monitoring and saw this, we were confused. If it's real, the very silent activity. Sensitivity is 7 microvolt per millimeter. We upped the sensitivity to 5, silent. Obviously, these are artifacts. An extensive study, including inborn errors of metabolism, was done without a definite etiology. Genetic studies was refused by his parents. First sonogram was negative, but serial follow-up sonograms showed a diffuse and progressive encephalomalacia. This is his brain MRI at the age of 3 weeks. FLAIR images, you can see the severely injured brain, multicystic encephalomalacia, and subdural hematomas at different timings over bilateral sides. Clinically, he had no eye contact with floppiness and was fed by NG tube. At the first day we took care of him, there were no endotrachea, no NG tubes. We didn't foresee that the outcome was so grave. EEG turns out to be the most early and precise indicator for prognosis. Focal abnormalities include abnormal focal background activity as well as focal spikes. Remember, we mentioned earlier that the normal sporadic multifocal shock waves for neonates gone at 48 weeks. So how we judge the focal epileptiform discharges as abnormal? It is not difficult as long as we check these parameters: incidence, persistence, and topography. If consistently and repeatedly on a given focal area. Secondly, morphology and complexity of waveforms. Thirdly, amplitude and duration. An amplitude of less than 75 microvolt, duration of less than 100 milliseconds, and a biphasic morphology are more benign. And lastly, polarity. We have seen this girl's EEG earlier, MSUD with a continuous background, yet too many spikes, or shock waves independently in the bilateral frontal areas. Interictal EEG is important, but ictal EEG is crucial. Electrical seizure activity consists of sustained rhythmic discharges with various morphologies, amplitudes, and frequencies. It often has a distinct beginning and ending with some degree of evolution in frequency, voltage, morphology, or location. A minimum 2 microvolt and duration of at least 10 seconds are required.